Hello and good morning, everybody. My name is Alyssa Dittner, and I am Assistant Director of the Bronchiectasis and NTM Association, the Education and Community. Today, I am joined by Dr. Timothy Aksamit. He is the Medical Director of the Bronchiectasis and NTM Association and Clinical Care Specialist Internist Pulmonologist for Mayo Clinic in Rochester, Minnesota. So welcome, everyone. I am also a registered respiratory therapist, so this topic is extremely passionate and valuable for the community. So, Dr. Aksamit, I will turn it over to you.
Thanks, Alyssa, and it's a great pleasure to be with all of you this morning from around the country and even internationally. Really an exciting time in the bronchiectasis space, and your presence here is really going to help move the ball forward, and you're part of the solution moving forward, not the problem, as they say. This is my disclosure slide, and I'll just welcome back Alyssa with her disclosures.
I have no disclosures, thank you.
There you go. And what we're going to do in this next 45 minutes or so prior to opening for Q&A, just to hit some highlights of the pathophysiology and epidemiology of bronchiectasis. We're going to share a little time on the bronchiectasis pathway, which we've endorsed at the association, the 2025 guidelines, and I'll mention the upcoming North American guidelines, which should be available later this summer through the CHEST publication. Talk a little bit about the Care Center Network and increasing awareness at the global level as well, and then give all of you a chance to weigh in and maybe give us some feedback and let us know what is on your mind and thoughts and concerns, and how we can help you inform your patients and your practice even better than you are doing now. I'm going to refer or have on the slides the image of this card. It's called the Bronchiectasis Pathway Card. It is something that the association has come up with. There are two sides and is available on PDF. And this is the second half of that card. And again, we'll mention this as we go through the presentation. There's a link at the bottom of this. I'm going to come back to this at the end of the presentation with a Q&A, and you certainly will be able to get this link, and maybe I'll have Alyssa maybe even place this in the chat so that if somebody wants to get to it, they can. So let's start out with just a little bit about the pathophysiology and epidemiology. I think many of you are going to be pretty familiar with this, so I don't want to spend too much time on this, but just to make sure we all get on the same page. And the first and foremost thing is to understand that bronchiectasis, when we think about it as a clinical disease, it's not only about the radiographic imaging, that is on a high-res chest CT scan of having bronchial dilatation, having bronchial wall thickening, maybe some mucus plugging, lack of tapering, but it is also associated with clinical symptoms. And those are very nonspecific: cough, sputum, having exacerbations, things that you interact with your patients on a day in, day out basis. We understand that there's a cycle that leads to this, comes from the etymology of dilated bronchial tubes, which again, with the circular construct of having an insult to the airway, oftentimes infection associated with infection and impaired mucociliary clearance leading to these structural changes. It's been described for the most part as a vicious vortex, and I'm going to come back to that. I like to think of it almost in a tornado fashion because this is a very dynamic process. We used to think about this being almost isolated to a single infection, Pseudomonas or non-Pseudomonas or staph, or some of the other infections that you're familiar with, but it really is a much more complicated set of interactions in relationships between these different domains. So I do want to spend a little time just to talk a little about each one of these components, which are very important in the overall presentation of the patients when they come to your clinic or in the hospital that you see. The first part is inflammation. We understand that most individuals have neutrophilic inflammation. Some have eosinophilic inflammation. We call that a Th2 response, kind of an asthma type of response. But the predominant inflammatory response is neutrophilic, and I'm going to come back to that and what those implications are. This inflammation that occurs, it does lead to the bronchial thickening that we see on the CT scan, and then the increased mucus production, which also may then feedback on itself and cause more inflammation. Infection oftentimes then is associated with this retention of mucus. It's a great environment for the germs that normally reside in our airway. Our lower airways are not sterile, of course, and they are populated by a whole variety of bacterial, fungal, and non-tuberculous mycobacterial organisms that then lead to infection that then interacts with priming, if you will, the inflammatory response and the impaired mucociliary clearance with this pooling or retention of secretions in the airway. It's a great place for these germs to grow, contribute to infection, more inflammation, and keep that dynamic set of relationships between these components ongoing, and then leading, of course, to lung damage. Patients may present with very mild disease, as portrayed on this left CT scan image, where there's just a little bit of bronchiectasis, some nodular infiltrates, and just a little mucus plugging. And then the patient on the right has a little bit more advanced bronchiectasis, more bronchial wall thickening, nodular infiltrates, and more extensive disease. And my only point is that there's a spectrum of disease from very minimal symptoms and minimal changes on the high-res CT to very advanced disease needing to think about transplant and other more definitive options. When we think about bronchiectasis, we understand too that this is a disease of aging. And so the top figures on the right hand of the slides, by the time we get to our 6th, 7th, and 8th decades of life, the increase goes up pretty dramatically. And at least in the US and North America, there's a predominance in women more so than men. That's not a same trend seen globally and depending on what the associations of bronchiectasis are. But we'll see this in an aging population. And again, I suspect it is very reflective of the patients you see in the hospital and in the clinics. Not surprisingly, the cost of bronchiectasis is really astronomical, if you will. And the more advanced the bronchiectasis is, and now I'm looking at the lower right-hand panel, the dark blue is the individuals with more advanced bronchiectasis, and they have the most expense. And those expenses really made up primarily with the cost of exacerbations. And that's in contrast to inhalers, which, for example, with asthma patients or even COPD patients, oftentimes the inhalers represent a large proportionate cost. So we really want to start to work on those exacerbations. And what does that look like from a global standpoint? On the far right of this cartoon, if you will, of healthcare resource utilization and economic impact of bronchiectasis, we can get an idea. Obviously, the healthcare systems vary globally, but in the US, the aggregate estimated cost is almost $15 billion a year. And there is a substantial cost across other countries and other parts of the globe. But in the US, given the cost of our healthcare system, it really is substantial. And so there's really great motivation, not only from a patient standpoint on how we feel, function, and survive, but also from a healthcare economic standpoint. When we think about what the associations are in bronchiectasis, I would say we have a limited ability to pin down the exact nature of bronchiectasis. I have a tendency personally to not use the word etiology. There are associations with certain kinds of infection, bacterial or mycobacteria, the NTM, non-tuberculous mycobacteria, some of the genetic associations with cystic fibrosis, primary ciliary dyskinesia, and alpha-1 antitrypsin deficiency, all of which you are familiar with. There are overlap syndromes with COPD and asthma. And we understand that when patients have bronchiectasis and COPD or bronchiectasis and asthma, their clinical course is worse. They have more severe disease, and it's something to be recognized. The other caveat, of course, is oftentimes patients are misdiagnosed with COPD or asthma for a number of years before a diagnosis of bronchiectasis is made. And this is in part going to be one of my pitches where you come in, because you see these patients in the clinic and in the hospital, and that they may or may not have a consideration of could they have bronchiectasis. There are other associated conditions, inflammatory bowel disease, very common to have reflux disease, which can exacerbate symptoms and worsen prognosis, and then chronic rhinosinusitis. I'm going to shift gears and go to this bronchiectasis pathway, and I shared an image of the card that you'll all have access to, and some of the, I think, highlights that are worth mentioning during this class today. First of all, when to suspect bronchiectasis. So who are those patients that you see that you should at least ask the question, could they or do they have bronchiectasis? And these are all very nonspecific symptoms, of course. Cough with sputum production being the most predominant, dyspnea, fatigue, chest pain, fever, hemoptysis, weight loss. This can occur for a large number of reasons. They're not very specific, but they are very common in bronchiectasis. And so what does that look like as far as red flags go? That is, when should you raise that possibility, talk to your colleagues, other providers about, could there be a component of bronchiectasis? When patients are using frequent antibiotics for respiratory infections, 2 or more per year, for example, they should at least have that question asked, could they have a component of bronchiectasis? If there's a sputum culture and that culture shows bacteria with Pseudomonas, or if there's non-tuberculous mycobacteria, NTM, show up in a sputum, MAC, Mycobacterium avium complex being the most common, that would certainly precipitate and flip the trigger to say, could they have bronchiectasis? If they're having refractory symptoms and they carry a diagnosis of asthma or COPD or both, and they're not getting better and they're having a refractory course, again, it should be entertained. And could this patient have bronchiectasis? And if they have non-resolving symptoms. So let's go to the card, and what does the diagnostic evaluation and data collection start to look like? The cornerstone, as I mentioned, is the imaging, and it's usually a high-resolution chest and CT scan. We make some assessment of what symptoms are using the modified MRC scale that you're all familiar with. CAT test, the CAAT, which is now the chronic airway assessment test. It used to be the COPD assessment test, but it's now been extended and used effectively in a validated way in bronchiectasis as well. And then these exacerbations, which not only result in increased symptoms, but increased costs, as we've talked about. Imaging, again, the gold standard is a high-resolution chest and CT scan. We see the dilation of the bronchial tubes. The adjacent blood vessels are much smaller. The ratio is generally greater than 1. Some individuals have described this as signet ring, or a ring with a jewel on it. The ring part goes onto the finger is the dilated bronchial tube, and the adjacent bronchial artery is the jewel that sits on top of the ring. There may be a lack of tapering, and then their airways may extend to the periphery, oftentimes within a half a centimeter of the pleural surface. The MRC scale you're very familiar with. I won't spend a lot of time with this, but this is something that then can be assessed on a regular basis, helps us understand where patients are. We use this in the context of what we call PROs, or patient-reported outcomes, symptom scoring that sometimes can be helpful in the clinic as well as in the hospital on where patients are with their levels of dyspnea. The CAT test that we talked about is a very simple, easily applied assessment tool that can be done on a daily basis and gives us a pretty good idea where patients are, especially if there's a change in the CAT score. The MID, or minimally important difference when there are changes, have been estimated to be around 4 or so. So it gives you some tools between the MRC and the CAT to be able to make some quantitative assessments where your patients are. Exacerbations generally involve a change in symptoms, and that is an increase in symptoms, usually occurring more than 24 or 48 hours, more cough, more sputum. It gets thicker, darker color, worsening shortness of breath, maybe hemoptysis, worsening fatigue. And we understand that with these exacerbations, the clinical impact is they have accelerated loss of lung function and decrease in pulmonary function tests. They have a worse health-related quality of life scores, these PROs, if you will, and they're at risk for increased hospitalizations and certainly healthcare use. So we want to be very proactive in this way when we think about exacerbations. And I might also add that exacerbations aren't the whole story. So we see patients, and you probably in your practices, whether they're in the clinic primarily maybe less so in the hospital, that have symptoms day in, day out, but they don't really have a change, but they're very symptomatic. They have a productive cough and they're having symptoms. So even if they're not having an acute exacerbation, those kinds of symptoms become really important and are reflective of what we call a disease activity. And I'm going to come back to this concept in just a little bit. Pulmonary function test gives us a great idea of whether or not there's lung impairment made by spirometry with or without lung volumes and diffusing capacity. We oftentimes do blood work looking for genetic abnormalities and other findings that may shed some light onto why they have the bronchiectasis or what the status is. Microbiology are integral. Cultures. We really want that to guide understanding where patients are. Do they have Pseudomonas or not Pseudomonas in their sputum from bacteria? Do they have mycobacteria? Are there fungal infections as well? And that really helps us understand how best to approach patients. The pulmonary function tests are mixed. It's not always obstructive. It's not always restrictive, but sometimes mixed. On occasion, patients will have normal pulmonary function with still symptomatic bronchiectasis. We understand as the lung impairment and pulmonary function worsens, they have more symptoms, more exacerbations, and more risk of a hospitalization. As an aside, with the inhaled corticosteroids, we use these very commonly in asthma, of course, and other inflammatory airways disease, and sometimes in COPD as well. But it really is not thought to be an integral component for bronchiectasis. And if patients have primarily bronchiectasis without another reason for an ICS, an inhaled corticosteroid like asthma or COPD, we try to get our patients off their inhaled corticosteroids. From a laboratory test, the blood work, CBC with a differential, do they have eosinophils? This Th2 response we talked about that suggests that they may have an inflammatory condition that may respond to certain therapies. Do they have immunoglobulins in the normal range or are they low? Do they need immunoglobulin replacement? Is there evidence on a C-reactive protein of systemic inflammatory response that might require intervention? We screen for alpha-1 antitrypsin deficiency with a level and a phenotype oftentimes, and then allergic bronchopulmonary aspergillosis, which is a relatively rare condition of individuals with centrally located bronchiectasis, reactive airways or asthma with eosinophils, and oftentimes very, very high IgE levels. Microbiology. One of my favorite images is this upper right-hand image, which is the Murray color chart. It's been around for a long time. This is something that you're all very familiar with. And as patients have darker, more volumes and more tenacious sputum, we understand that that does in fact reflect more disease activity. And that by scoring systems, by exacerbations, and even by mortality, that color of the sputum that you are so keen to pick up on really tells us a lot about the clinical course and is something that should not be unassessed. It's an easy thing to assess with patients. And when we see this again, trying to sort out what pathogens they may or may not have in their sputum, whether it be bacteria, mycobacteria, or fungi. When we look at other less common associations of bronchiectasis, we try to sort out, could the patient have autoimmune disorders or connective tissue disease, rheumatoid arthritis, vasculitis, inflammatory bowel disease? Does the person have GERD or aspiration, which is exceedingly common in this patient cohort? Do they have active infections that need to be treated? Could they have decreased immunoglobulins or other immunodeficiencies? So we see less and less individuals with HIV-related bronchiectasis, but it can happen. And then this whole overlap, either related to genetic abnormalities like CF, cystic fibrosis, PCD, primary ciliary dyskinesia, or other associations that we do treat those on a very aggressive and regular basis. And I want to come back to this concept about activity and structural lung disease. That is to say, when patients come to us and they're in the hospital or in their clinic and they've got very advanced bronchiectasis and they've got Pseudomonas and their pulmonary function is way down, the disease is there, but it's very advanced. It's late in the process. And so what we've come to appreciate is we want to recognize disease early. That is to say, Well, you want to try to identify individuals that have bronchiectasis or are at risk, that have disease activity before they get the structural lung disease and the terrible findings on the CT scan, because by that time the doors are open, the horses are gone, and the house is burning. And the analogy used in this reference is if the house is on fire and there's disease activity, this ongoing inflammatory response with or without infection, you don't want to wait till the house burns down and you're just left to the ashes before you put the fire out. If you put the fire out sooner, the house will stay intact. And so we're using an analogous type of approach to try to identify these individuals before they have very advanced disease. And if we're very aggressive, we think that we may be able to change the natural course of the disease process. So again, we don't want to let the house burn down. We want to intervene earlier. And that's where you come in with the other types of activities that we can do to try to put that fire out. Other types of scoring systems that have been used to assess the severity, and one of the most common is the Bronchiectasis Severity Index, or the BSI. It's made up by a compilation of age, patient's BMI, are they losing weight, is the FEV1 down, are they requiring hospitalizations, how many exacerbations, the MRC score, do they have Pseudomonas, that sort of thing. And we understand that as that BSI goes up, it gives us a quantitative assessment to try to give us an idea of what their risk over a 4-year period is for mortality and hospitalizations. And not surprisingly, as the BSI worsens, the scores go higher, we have an increased risk of hospitalizations and mortality. And if you just take a look at the lower portion of the right-hand panel, for example, by the time we have a severe BSI described as 9 or greater, that the mortality over a 4-year period is between 10 and 30%. And so again, that's late in the disease process. We want to try to get to that fire before that occurs. So when we start thinking about what can we do to try to put that fire out, there are several ways that we approach this with airway clearance. We treat comorbidities, do supportive care measurements, infection management, and then consider anti-inflammatory disease, not with ICS, but with other anti-inflammatory strategies, and I'll come to. But the key I want you to all walk away from is that there isn't one size that fits all. And what works for one patient won't work for others. When we think of that construct of having that vicious vortex of the inflammation, the infection, the impaired mucociliary clearance, and their structural lung disease, not everybody's in the same spot. So we have to accommodate this and individualize your treatment for the patients. And that's where you come in, again, making assessments on an individualized basis with precision medicine so that we can give our patients the very, very best care, and to walk away and have patients understand that not one size fits all. Because oftentimes they come across things, say, yeah, it's the best thing that came along since sliced bread. I've got to do this. Well, maybe, maybe not, because what works for one patient with bronchiectasis may or may not be very effective for others. And we oftentimes, not only on the initial visit, whether you see somebody in the hospital when they come in with an exacerbation, or they're coming into the clinic with a new diagnosis, but to see them in a longitudinal fashion. As the mantra goes, repetition is the mother of learning. And so I think to have frequent interaction between patients and yourself, to have you as an integral part of the multidisciplinary team for effective management of bronchiectasis is critical. And so this isn't a one and done type of thing as well. At this point, and I'm going to turn this over to my colleague, Alyssa, who's an extraordinary respiratory therapist with great experience to share some of her perspectives that I think will resonate with many of you. Alyssa.
Thank you, Dr. Aksamit. So the number one concern from patients with bronchiectasis is a chronic persistent cough, and that is with or without mucus. So many describe this cough as frustrating and exhausting, and it can have a profound impact on a person's quality of life. The airways are widened and misshapen. It really makes it hard for patients to move that mucus from the smaller airways up. So for this reason, airway clearance therapy is going to be a fundamental part of managing bronchiectasis. Airway clearance can take many forms and should be matched to each person's needs and ability. So, when choosing an airway clearance plan, it's important to consider how much time the person can spend on and dedicate to airway clearance. It's important to consider their physical strength and stamina and their level of mobility. And then also looking at what is their access to devices and what does their support system look like. As Dr. Aksamit has mentioned, it is not a one-size-fits-all approach. So that's where we really lean on our expertise and our input when you are in the clinic, when you are in the hospital system to evaluate what they're doing. So when we talk about airway clearance, this could include medications, so bronchodilators if indicated, hypertonic saline nebulized to create a hostile environment for that bacteria and to hydrate and thin that mucus. So when we look at other options, we have manual airway clearance through use of gravity and positioning. That includes deep breathing techniques like active cycle breathing, autogenic drainage, and huff cough. And those are just to name a few. There's some more. And then looking at using devices. So these devices could be the OPEP devices. So your oscillatory positive expiratory pressure, your high frequency chest wall oscillation, your interpulmonary percussive ventilation, your positive expiratory pressure devices, all use some kind of variation of positive pressure, oscillation, and external percussion, or even a combination of these methods. But these are going to be what patients can use to help mobilize that mucus and using those devices to make that more progressive and effective. So there are new devices that are coming to market. I actually was just at a conference and I learned about 2 new devices that are coming out in this next year. So this space, it continues to grow. So just stay curious and look and learn about how these mechanisms work. So last year we did do a deeper dive on the specific devices in honor of World Bronchiectasis Day, and this was hosted by the Respiratory Associates. And you can find that webinar on the Bronchiectasis and NTM Association page on our YouTube page. So keep an eye out for that if you want more information about those specific devices. So another area to focus on for these patients with airway clearance is exercise and pulmonary rehab. These are super effective methods to reducing atelectasis, enhancing air movement, and improving the overall quality of life. Any sort of physical activity not only can boost a person's mood, but also alleviates anxiety and depression, which is highly prevalent in this group as well. So really great things to be able to educate the patients about. This is achieved by increasing levels of good feeling hormones and chemicals in the brain, which are your endorphins, your norepinephrine, and your serotonin and your dopamine. So looking at what types of airway clearance is going to be appropriate to the patient, taking all of those items into consideration when you're looking to match up the specific device or specific plan, always reevaluating your patient because something could work from last year and things have changed and it might be different. Dr. Aksamit, you can go ahead and go to the next slide and I'll pass it back to you.
Thanks, Alyssa. And again, just to emphasize that you are probably the pivotal part in a core treatment program for patients with bronchiectasis. And it's not to diminish these other components I'm going to mention, but this airway clearance is critical. This is a team concept, and you're the quarterback, if you will, to a large extent, manifest by the approach to airway clearance and the options available, which have to be individualized. We already have touched on the comorbidities. And again, this is where that team concept comes in. Not only do we have to address COPD and asthma if they're present, but maybe ENT needs to be involved for rhinosinusitis, GI for refractory reflux disease, the rheumatologist for autoimmune disease, or the immunologist if there's an immune deficiency. So not to hesitate, but this has to be a team concept, a multidisciplinary approach if we're going to have effective care. Not surprisingly, patients are in great need of support. Oftentimes their BMIs are low, they need nutrition, sometimes in a formal assessment by the nutritionist. This has a big impact chronic disease management with mental health. And this is a big burden, as Alyssa had shared, not only to do their daily therapies, but to have these symptoms. And it has a negative impact on how patients feel and function in this way. Supplemental action if needed, vaccinations, and of course, as chest providers, we all should take that opportunity if there's any smoking involved, is to have smoking cessation. Infection management become important strategies, whether for acute infections with acute antibiotics, inhaled antibiotics, or IV antibiotics, and then sometimes working with not only pulmonary providers, but ID providers and other individuals such as PharmDs, pharmacists, to help coordinate and deliver complex antimicrobial regimens. The anti-inflammatory component, we say, is an integral part of this vicious vortex, the neutrophilic in particular. And for that, not only do we want to avoid the inhaled corticosteroids, but there's a new class of medicine called DPP-1 inhibitors that work specifically against the neutrophilic inflammation. There is a brensocatib or Brensupri that's been FDA approved as of last August. And there are others in that same class being investigated as we speak in a broader way for patients with bronchiectasis. And the label is for non-CF bronchiectasis, but not necessarily with exacerbations, at least the FDA approval. And that's in contrast to the European, the EMA regulatory agency, which does require 2 or more exacerbations, which was part of the study enrollment that provided the data for the FDA approval. Macrolides, so azithromycin, clarithromycin, and erythromycin, not only have antimicrobial effect, but they also have anti-inflammatory or immunomodulatory effects. And they've been around for the better part of 10 years, and they have also an impact on this inflammatory response. And there is positive signals, especially for those that are having frequent exacerbations or lots of disease activity trying to put out this fire. The caveat I would share with you that here in the US and North America, we see a lot of NTM, non-tuberculous mycobacteria. And what we don't want to do is have patients exposed to monotherapy with a macrolide, even with good intent, azithromycin to reduce inflammation or have an immunomodulatory impact, but then develop macrolide-resistant MAC, which becomes a much more complicated problem for patients. So again, this is part of that team concept to work together to find what works best for an individual patient. Follow-up monitoring, longitudinal follow-up is essential. This can't be a single consult and then patients don't return. They need to see you again, in my opinion, for a kind of a refresher on the airway clearance because it's such an integral part. And the frequency and timing of that follow-up really is dependent on how patients do. Anywhere from about every 3 to 6 months to maybe once a year or just as indicated, and then to make assessments when they do come back. Some very special considerations are trying to get patients enrolled into care center networks, that is specialized centers that are now around the U.S. They need to see a surgeon if there's localized bronchiectasis to just one lobe that's symptomatic and not responding to therapy. That may be something that needs to be considered, or hemoptysis. And in most advanced cases, then either lung transplant or even palliative care. So again, there is a spectrum of disease severity as well as activity that needs to be addressed. When we think about mycobacteria in particular, almost everyone with NTM or non-tuberculous mycobacteria have bronchiectasis, but not everybody with bronchiectasis gets NTM. Probably about 1/3 to 40% in the US and North American experience. And this diagnosis made with frequent sputum collections, looking for these mycobacteria, and when present, oftentimes require a multi-drug antimicrobial regimen, sometimes 3, 4, or 5 antibiotics for 18, 24 months. So a very complex regimen that requires this multidisciplinary team, including oftentimes infectious disease and pharmacy, to help come up with an effective strategy. Some instances, doing airway clearance and treating bacterial pathogens is enough to stabilize symptoms and radiograph and pulmonary function tests. At other times, we need to advance and again tap into this multidisciplinary team and begin a antimicrobial regimen. The respiratory therapists, I can't emphasize enough. You're our point people and really the key element, in my opinion, to successful longitudinal management. And at this, I'm going to turn it back over to Alyssa to share some additional perspectives. Alyssa.
Thank you, Dr. Aksamit. So recently I attended a patient conference to represent the association, and when the attendees learned that I was a respiratory therapist, they were thrilled and they asked me a multitude of questions. They expressed that they often lacked access to a respiratory therapist, and when they do have access, the time spent with them is usually very limited. Airway clearance, again, is that fundamental treatment. I challenge you, regardless of your role, whether that be at bedside, in the clinic, working for home care, be aware of your impact. Question the diagnosis if your patient has COPD and asthma, frequent lung infections, or experience ongoing exacerbations. They could have undiagnosed bronchiectasis. For example, up to 69% of those diagnosed with COPD can have overlapping bronchiectasis according to the GOLD guidelines. Patients often go undiagnosed due to similar presentation of bronchiectasis and other respiratory diseases. But as you can see through this presentation, treatment is not the same. It is always unique per patient, per what they got going on. I actually read that it can take between 12 to 17 years for a patient to receive the correct diagnosis. So recently, I actually interviewed patients for World Bronchiectasis Day, and one individual mentioned that she was misdiagnosed with pancreatic cancer, while another one was misdiagnosed with allergies, and another one lung cancer. And many patients, they just often expressed that they fell through the cracks for years because they weren't getting that investigation that they needed because bronchiectasis wasn't known about. So we need to make sure that these people are getting appropriate care, and that all starts with education. So take every single opportunity to educate yourself and others about bronchiectasis to help bridge these gaps. For many patients, you may be the only respiratory therapist they see. So explain the disease, review airway clearance techniques, help individualize airway treatment plans, and look for ways to optimize inhaler and nebulizer use as needed. Always strive to understand your patient. Where are they coming from? What are they going through? What brings them into the hospital? And then seek to be understood. So there are many opportunities to have meaningful conversations with patients about their symptoms, airway clearance, and just overall lung health. This can naturally fit into routine interactions, such as, breathing assessments. Maybe you're doing a pulmonary function test, bedside spirometry, 6-minute walk test, as well as through involvement in pulmonary rehab. So at my last facility, I taught a 1-hour class each month for patients in pulmonary rehab, sharing practical education and then answering questions regarding COPD and bronchiectasis. Now, this wasn't initially part of my job duties, but it was an area that I seen that there was a huge gap in. So it was something that I had gotten myself involved in. Respiratory therapists can also make a big impact through care coordination, or you might know it as pulmonary navigator roles. These programs support therapists in educating their patient and ultimately helping to reduce readmissions, which is important for your hospital. It's important for the economy, and it's important for that patient so that they are not progressing with their disease. So ultimately, culture we are in today, the average appointment times that patients are really allotted is 17.4 minutes. And that's with the patient speaking about 5.3 and the provider speaking about 5.2. So the information that we provide is extremely valuable. By being informed and being able to recognize what these signs and symptoms are of bronchiectasis, RTs can help patients receive appropriate testing, ask the right questions, and understand the importance of consistent airway clearance and even their proper technique. All of this helps improve a person's quality of life, and it helps the person to receive that timely diagnosis and treatment that Dr. Aksamit had mentioned earlier. And I'll pass it back to you.
Thanks, Alyssa, and really fantastic perspectives. And again, emphasizing the role that you all have at various stages of the patient's journey, whether they're in the hospital or the clinic or rehab or in whatever venue you interact with patients. So bringing this home in this last 5 minutes or so, how does this fit into a bigger picture, the current guidelines, and then trying to raise awareness? We talked a little bit about this vicious vortex, and each one of those components is emphasized treating the inflammation if it's present and appropriate, infection with specific infections with either oral, inhaled, or IV antibiotics, impaired mucociliary clearance, airway clearance as emphasized and aptly put by Alyssa, 2 green boxes, hugely important to not only do once when you interact for the initial visit, but then longitudinally as well. And I'm an avid believer of pulmonary rehab as well, and emphasized as well. So in order to try to move the ball forward, you're also part of the solution in increasing awareness, not only in your practice, but amongst your community and your colleagues. In this regard, the Bronchiectasis and NTM Association has been formed over the last couple of years, trying to establish specialized centers of care to give you all the support that you need to provide the very, very best care in a timely fashion for your patients. What that care center network looks like, it's not only about clinical healthcare delivery, but about research, about education. And as the mantra goes, and as Alyssa mentioned, one of my strong feelings about success is education, education, education. Not only for patients and their caregivers, but for the community and for your providers. You're the integral part to talk to your other pulmonary providers, your infectious disease providers, internal medicine, family medicine, the APPs. You're an integral part to help inform all of them to move this ball forward. The care center network in the U.S. is continuing to grow. Our goal is between 100 and 150 centers around the country and virtually every state to be able to provide this care on a referral basis, and then to provide you all with the support that you need at the local level to deliver this timely, high-quality care. There's lots of resources available through the association at broncandntm.org. Download the library, podcasts, newsletters, the social. We can talk a little bit about this in the Q&A period. There are materials in multiple languages, over 10 languages about bronchiectasis, Spanish being the most common. We see Chinese as the second non-English language used, but then we have, again, over 10 languages in these materials that are available. We have global partners raising awareness at the World Bronchiectasis Day, and part the timing of this presentation on the 1st of July every year. Our partners around the globe are virtually on every continent and continue to grow with a great deal of interest, just given the large amount of unmet need amongst our patients and caregivers. Talked a little bit about the World Bronchiectasis Day resources, all the languages that are available with many of the materials that may be appropriate in your practices. And I think I will come to a close there and just emphasize once more and give a shout out and thanks to my colleague Alyssa for her great thoughts and emphasis that you are part of the solution here to inform not only your patients and their caregivers, but the rest of your community and the respiratory therapy community, as well as the providers, the pulmonary group, the ID docs, and everyone. And that individualizing this care approach really will provide a great pathway to improve best care. And just to emphasize once more that these cards are available by download if necessary. And I'm going to stop there, and then we'll open things up for a few questions if they are amongst the group. Thank you for your time.